Welcome to this explainer. Okay, if there is literally one thing that causes universal headaches in any medical practice, it's gotta be a surprise Medicare billing update, right? Well, today we're setting our sights firmly on 2026. We are looking at a highly anticipated addition to the Annual Wellness Visit, or AWV, that is absolutely going to change how you document and bill for preventive care. So let's just dive right in and get your workflows prepped long before the actual rollout.
January 1st, 2026. Mark your calendars, folks, because that is exactly when Medicare's new optional element for the AWV officially takes effect. Now, I know 2026 might feel like it's a little ways off, but let's be real. In the fast-paced world of electronic health record updates, it is practically tomorrow. Getting a head start right now? That's exactly how successful practices avoid those dreaded, denied claims on day one.
You know, what's really fascinating here is how Medicare is formally integrating physical activity and nutrition assessments right into the wellness visit itself. We aren't just talking about a casual, hey, how's your diet conversation anymore. No, Medicare is specifically categorizing this as a standardized, evidence-based assessment. It's honestly a massive shift. They are moving toward proactively quantifying lifestyle factors as a core, measurable component of preventative care.
But hold on, before we unpack the mechanics of this brand new assessment, we really have to review the baseline rules. To even consider this new element, you first need to know who actually qualifies for the underlying annual wellness visit, which, as a reminder, you report with HCPCS Level 2 codes G0438 and G0439. Because think about it, if the core AWV gets denied, this new add-on is just going to be a massive administrative headache.
So to get that AWV covered, your beneficiaries are essentially running on two distinct 12-month clocks. First up, they absolutely cannot be within 12 months of the effective date of their very first Medicare Part B coverage. Second, they can't have had an initial preventative physical exam, or another AWV, within the past 12 months. Keeping those two timers perfectly straight, that is your absolute baseline for compliance right there.
Okay, with those baselines set, we can finally introduce the star of the show, HCPCS Level 2 code G0136. This is the exact code you'll be using to report this new standardized assessment of physical activity and nutrition. And pay close attention to the specific time requirement built right into the definition. It has to take between 5 to 15 minutes. And guys, this isn't just a gentle suggestion. It's a critical, hard and fast documentation requirement your clinical staff must chart to actually get paid.
And here is a crucial little detail that was recently added to the 2026 revised descriptor, a strict 6-month limit. Sure, you can technically perform the assessment more often, but Medicare is putting a hard, non-negotiable boundary at a 6-month interval between each billing of G0136. If you try to bill it at month 5, yeah, you're looking at an automatic denial for sure.
Now, simply identifying the code is really only half the battle. We also need to figure out how to bill this correctly without causing any friction with your patients. And honestly, this is exactly where the financial mechanics get a bit complex and where practices are, most likely to make some pretty costly errors.
What we're looking at here is a classic billing showdown, and it all depends on what else you actually do that day. In scenario 1, you bill G0136 on the exact same date as an annual wellness visit. But in the competing scenario, you bill that exact same code alongside a standard evaluation and management service, or maybe a behavioral health service. And the financial implications for your patient? They are entirely different depending on which path the visit takes.
Let's look at that first scenario. When you pair G0136 with an AWV, applying modifier 33 is basically your magic key. Modifier 33 is the code for preventive services, so appending it to G0136 on the same date as an AWV acts as a mechanism to totally waive the patient's copayment and deductible. It's effectively a free, proactive assessment for the patient, which is awesome.
However, and this is a big however, you need to be incredibly careful here. If you provide G0136 on the same date as an E&M service or a behavioral health service, boom, that waiver completely disappears. Standard cost sharing kicks in immediately, meaning the patient is going to be fully responsible for their copayment and their deductible for this assessment. This distinction is obviously vital for your billing department, but I'd argue it's even more vital for your front desk.
Why the front desk, you ask? Well, because Medicare's strict guidelines actually dictates that the patient must be informed of this charge prior to rendering the service. I mean, literally nobody likes the surprise medical bill, right? Especially for an assessment they probably assumed was just a free preventative perk.
Proactive communication here is hands down your best defense to protect your practice's reputation and, most importantly, maintain patient trust.
So to wrap up this explainer, it is crystal clear that Medicare is signaling a massive shift toward actually quantifying diet and exercise within the clinical setting. The codes are there, the modifiers are totally clear, and the frequency limits are set in stone. But here's the real question I want to leave you with. How is your practice going to adapt its internal billing workflows, its time tracking, and its patient communication strategies to successfully implement 0136 by 2026? The clock is absolutely ticking, so it is definitely time to start planning.